A little bit like the NFL, we're going to have a 2-minute warning. I'm allowing myself 20 minutes, so at 18, my alarm will go off. So you can think about questions. I do have sort of a rush at the end, the 2-minute drill at the end before the questions. I want to thank you for the opportunity to talk to you about Honoring Choices Wisconsin, improving advanced care planning across the state. And for those people that I see a few internists in the audience, you're going to see ACP, which has nothing to do with American College of Physicians in this particular talk. Honoring Choices Wisconsin is an initiative of your Wisconsin Medical Society, and I know some of you are members, and if you're not a member, we're always welcoming more. So Honoring Choices Wisconsin, and that's me. And I start out by, I'm a primary care physician, and so I talk to my patients about this all the time. You know, we do a lot of things in meaningful use, and one of the meaningful use things we do when a patient comes to the office is we ask them if they're smoking. And when they come back, we ask them if they're smoking. And they come back, we ask them if they're smoking, whether they're smoking or not. And that's because that's considered meaningful use. And so one of the things I'm going to have you mull over in your mind is maybe we should be talking more about advanced care planning. Not that we shouldn't talk about smoking, that's an important thing. But smoking illustrates that we are merely presidential advisors. Our patients get to decide whether or not to smoke and whether or not they choose to stop to smoke. We can give them excellent advice as their presidential advisor of their health care, but it's up to them to act, which also applies to advanced care planning. So I'm going to talk about 6 presidents that you see here in chronological order, although unfortunately it's a little bit at times out of order. We start out with President Kennedy and President Johnson. Actually, I'm going to take you back to before either one had the nomination of their party in 1959. Then Senator Kennedy was vying against Senator Johnson to be the spokesperson for the Democratic Party. The Hispanic coalition of the Democratic Party backed Senator Kennedy. And it wasn't because they really loved Senator Kennedy. They really didn't know a lot about Senator Kennedy from the Northeast. But Senator Johnson was a guy from Texas, and they knew lots about him. So they backed Senator Kennedy, and he did get the nomination. I'm not saying that's why he got the nomination. But then the candidate for the Democratic Party chose Lyndon Johnson to be his running mate. I'm sure that then candidate Kennedy talked to many people about who he should pick as his running mate. And history tells us that his brother Bobby was not thrilled at his choice. But he thought Senator Johnson would be his best running mate because he believed Senator Johnson could deliver Texas to his column of electoral votes. And so who better than the president to pick their vice president? We're going to come back to that in a little bit. Back in November, we recognized the 50th anniversary of the death of President Kennedy. And so now I ask my patients, what would have made that worse? And most of my patients remember it rather vividly, and they can't imagine anything worse than that. And I point out to them what would have been worse is if our forefathers had not created the role and process of the vice president. And this will, as you can see very soon, if you haven't figured it all out already, typifies how a healthcare power of attorney, which is part of advanced care planning, is supposed to work. The other thing we've learned is that now historically, President Johnson is known as the civil rights president, and he typifies how a healthcare power of attorney is supposed to work. The day before President Kennedy's death, Vice President Johnson was not exactly one of the stronger people pro-civil rights. But he understood that as filling in for the president, that's all the vice president does. The vice president is speaking for the president. He is given the title of president, but it's his obligation to carry out the will of the president. And clearly civil rights was part of the agenda of President Kennedy. And one thing President Johnson knew how to do was get legislation passed. And at the time, they were called Dixiecrats. And he got his Dixiecrats to vote for civil rights. And probably a lot of those should be in the book that Kennedy wrote about profiles of courage, because most of them never served in Congress again, because their constituents may not have thought this was a great idea. But it goes to how our health care power of attorney is supposed to work. Next, I'm going to talk about Richard Nixon in a roundabout way. Most of us know that if anything happens to the president, the vice president is obligated to take over. But if the vice president's not available, it goes to the Speaker of the House. So I had an appointment not so long ago that was arranged by the, if you will, the Speaker of the House, the daughter of the patient, to come in with her dad, who was vice president. And the mom was there too. And as we say in the trade, the lights were on for the mom, but nobody was home. The power of attorney had been activated. And the husband was now the president, so to speak, of his wife's care. They had the document with them. The document clearly, written at a time when the wife was in better shape, indicated her wishes to avoid extraordinary care. As some of us have experienced with family members, he was quite clear that she was not going to die on his watch. He was going to use whatever means that was necessary to keep her alive, including CPR, ventilators, tube feedings, etc. And he could verbalize that he knew this was not what his wife wanted, but it was what he wanted. The daughter was not happy about this. So I offered the husband the opportunity to do what no other president except Richard Nixon has done, to the best of my knowledge. And he said, "What was that?" And I said, "He quit." The president can't quit. We learned a year ago, is it now, that, or so, that the Pope can quit. No, not a lot of people weren't even aware of that possibility. Well, he was really quite clear. It took him a moment to respond. "Oh, I wouldn't do that because my daughter let my wife die." So this does not represent the best of advanced care planning. Now, I did offer the daughter the only hope she had, and I checked with legal people about this. The daughter, as Speaker of the House, so to speak, had the right to impeach her dad because he was not following his wife's wishes. She chose not to do that. I can certainly understand that. The ongoing story, as far as I know, they're all still alive. Not Richard Nixon. When you do your health care power of attorney, it's important to let people know what the deal is. Most of us understand that if anything happens to the president, it's the vice president. And you would think that those that live within the beltway that have been brought up on politics would understand this. But when something bad happens, and we've seen this in families, are families any different than our leaders? Not really. President Reagan gets shot. And General Haig, who was on the cabinet of President Reagan, gets up in the White House and tells the world he's in charge. That's the nice thing about having an advanced care plan. You let the world who you want to be in charge, and General Haig was wrong. Some of my patients tell me, "Oh, I don't want to fill out a health care power of attorney. I don't want to give up control." Well, this control thing is actually using, first off, the example of Kennedy and civil rights, but we can also see it with George W. Bush, because while he was in office, he underwent a traditional colonoscopy. And there was a little thing in the news that temporarily Vice President Cheney was in charge. When he came to and was deemed ready to return to the field of play, sticking with the football metaphor, he took over again. So I would actually advocate for my patients that tell me they're going to lose control. They have more control than they would if they didn't do the doctor. The last president is our current president. Teeny little news article about him. That indeed, he has done his own advanced care plan. I believe other presidents have, they just haven't they've chosen not to talk about it. I don't really understand why, but I'm glad he talked about it. Moving on to what advanced care planning is. It's really a process of understanding reflecting on your values, the patient's values, and your values only when you're talking about your health. Your patient's values are determined by your patients. And discussing potential future medical decisions, including end-of-life preferences. It is not a form or a one-time event. And the people at Medical Society, I always press for the healthcare power of attorney form. That's only part of it. Your vice president really can't carry it out unless they know what your wishes are. Your wishes may evolve with time. And in my own case, if I keel over right now, what a great place to keel over. Because we got doctors in the room, we have equipment nearby, and just we're clear, I'd like everything done. Now, part of that is I have my healthcare power of attorney that I know that has my back. Because most of us in this room know that healthcare can be pretty ugly. And as far as what we do to some of our patients, that if they were prisoners at Guantanamo, it'd be clearly against the Geneva Convention. But we do it because patients want us to, or we do it because we believe that the patients want us to, but we don't know. We tend to default to more, not less, when we don't know. And so do families. I feel that frequently people don't understand their treatment options. And they don't, everything we do has a certain amount of risk and benefit. There's no treatment that's 100% safe. And sometimes doing less actually results in doing more. There was a study of cancer patients that, and I don't know how you get to a study like this, but the patients had to agree that they'd be randomized to active treatment versus no treatment. And the no treatment people actually lived longer and they had fewer side effects because they weren't being treated. And I think we have trouble doing that because a little bit like that gentleman I talked about earlier, I grew up at a time when if somebody died when you were on call overnight, the question in the morning report was, what did you do? What did you do wrong that let them die? But maybe none of you ever had that experience. And that's how come I think that this cannot be done in a one visit thing. I think people need to think about it. I try to bring it up in the office frequently. I give them the paperwork, and I try to let them know that they have the right to carry this out. So it's important so you get the care you want, especially if you lose the ability to communicate. Is to, there have been studies that when families don't know what the plan is, because there is no plan, and the patient eventually dies, there is a great remorse that falls into two camps. One camp is, we didn't do enough. If we had only done a little bit more, it would have gotten better. The other camp, we did too much. We should have thrown in the towel earlier because we knew they were dying. This is all driven by the fact that they have no clue what the plan was. Everyone in this room is a healthcare leader, whether you like it or not. And the Medical Society polled physicians in the state of Wisconsin. We had roughly 1,200 responses. 61% of physicians polled indicated they had already done an advanced care plan. You're going to see later on, there's a slide, the general population 2 years ago was around 23%. The other problem, this is where we are at the year 2000, and this is sort of about halfway between these maps. We have an aging population. We all know we're spending an awful lot of money the last 6 months of life. But unlike the NFL, we don't have a 6-month warning. So I think it's really important that we give people the tools so that they can let their loved ones know what they want should things go bad. The darker the blue, and it's not the best slide for projection, but the darker the blue just indicates that some of these counties are going to have over 27% of the population will be over 65. And as I said earlier, if you don't express your preferences, decisions are made for you without your input, without planning. And usually that's to do more, which is fine if that's what you want. The care you receive may not reflect your wishes, values, or beliefs. Your healthcare providers may not know your treatment preferences. And your family may be left wondering if they're making the right decision. The fact, 60% of people say that making sure their family is not burdened by tough decisions is extremely important. 56% have not communicated their end-of-life wishes. Now, the other thing that we see that happens is that there'll be a large family, and you may have talked to your son or daughter, and they came away with an understanding of what they thought you said. But your daughter or son, who you had a similar conversation with, may have interpreted it differently, and they don't have anything to focus on because it's not written. And most of us know in healthcare it's not written. It didn't happen. And we like to practice evidence-based medicine. 70% of people say they prefer to die at home in their own bed. About 70% in fact die in a hospital, nursing home, or long-term care facility. 80% of people say that if seriously injured, they would want to talk to their doctor about end-of-life care. 7% report having had an end-of-life discussion with their physician. I believe that these discussions are far more effective when it's not a crisis. 75% of physicians whose patients had an advance directive were not aware that it existed, and that's part of our project, is to make sure that information is available. 82% of people say it's important to put their wishes in writing, but only 23% have actually done it. So the Medical Society took this as an opportunity, knowing that physicians were well ahead of the curve as far as doing this as opposed to non-physicians, that we would bring people together that would have an interest in this. We would try to come up with an effort that would meet everyone's needs. So we would respectfully listen to how people felt about this. And part of this is to improve the patient's experience. The information I've given earlier about patients' families is a study in the British Medical Journal done in Australia, as Australia converted to this process. And they found that survivor satisfaction, you'd say, well, we don't take care of the family, but we do take care of the family. And survivor satisfaction went way up in Australia with people, and they were clever enough to do this plan as they were implementing this system in Australia. Patients also have the feeling that they have more to say about their health care, which of course they had more to say all the time, they just didn't always listen. And it's to help patients know that it's okay to talk about a topic that, and in my own case, I did my advanced care plan, but my attorney told me to. There's my 2-minute warning. So I'm going to speed things up, and I'm going to ask for you, besides giving me 5 stars for the talk, I would ask that you should recognize on your calendar, April 16th is National Decision Day. That's April 16th. If you've not done your own, you should do your own. And if it's good for you, it's probably good for your family. So any adult in your family, some of you have adult children, you may even have adult grandchildren, for all I know. They should all have their own advanced care plan. And they can say, well, they're young, and nothing bad's going to happen to them. Their, of course, biggest risk would be an auto crash. So they should wear their seatbelt too. Encourage your colleagues in the area you work in or the clinic you work in to do theirs. And then when the physicians have done theirs, encourage the other colleagues in the areas you work in to do theirs. Find out what your percentage is. And then compare it to the percentage of the patients you see. And have they done theirs? Because if it's good enough for you and it's good enough for your family and you think your colleagues should do it, shouldn't your patients be doing it? And you can show leadership in that way. So, and Columbia St. Mary's has all the material you possibly need. Mark Propenchek is the leader here at Columbia St. Mary's doing that. And he'd be happy to go talk. He's talked to many groups. I have had the pleasure of talking to religious leaders of every religion, well, not every religion I can think of, but many. And it's interesting, they have a high regard for physicians, But what they see is the family comes to them and the family says, what do we do with our mother or father? And they don't really know because they don't know how sick the mother or father is. And they feel the patients, the family doesn't, when the family comes to them, they don't understand how sick they really are. And it's interesting that all of these religious leaders, in one way or another, said they all believe we are from God. And when we are ready to die, our souls actually return, or yearn to return to God. And I'm paraphrasing it, of course, and I all said it a little bit differently, but I like the phraseology. Woe be it to that doctor, nurse, or family member that stands in the way of that soul returning to God. So, on that note, any questions? No questions. I hope you've all done yours. Right. Well, I do tell my patients that we like to, in some ways we're like Oz and the Wizard of Oz. We're supposed to have all the answers. The fact of the matter is we don't always know all the answers. And that's only being honest. Thank you very much for your attention and the opportunity.